Tonight I'm going to talk about nutrition during metabolic stress. So one of the first body systems to be affected by impaired nutrition is the immune system. Metabolic stress subdues the immune system's ability to protect the body. So this is going to be even worse if the patient is already malnourished. So you can see how this deadly cycle is going to occur, where recovery is going to require breaking this circle. A well-nourished body will not be hurt by infection or disease the same way that a poorly nourished one is. For example, just look at developing countries where infection is the leading cause of death and protein energy malnutrition is rampant. So what this slide here is showing you is just some of the effects of malnutrition on the immune function. I'm not going to ask you specific questions. This is more pathology, but I wanted to show this is the reason why. Why do you need to make sure you're not malnourished? Well, look at things like your microvilli here flatten, which just means that you're not going to, the bioavailability of your nutrients are going to be decreased. Things like if you're not able to make the same cells or all the cells you need for your immune function, how do you expect immune function to be functioning well? So we need to make sure patients who are malnourished are brought back into good nutrition, and patients who are in good nutrition, we do not let them fall into become malnourished. So let's talk about the stress response. So what this is showing here is that, first of all, the magnitude of the stress response is in proportion to the duration of the stress. So your body, remember, always wants to be in homeostasis. So when you go through this ebb and flow phase, this is actually your body's attempt to heal and resolve the inflammation. So let's talk about first the ebb phase. The ebb phase usually lasts for 12 to 24 hours and it's going to be characterized by shock with hypovolemia and diminished tissue oxygenation. Things like you can see in this little table right here, your oxygen consumption, your cardiac output, your plasma volume, all go down. You're hypothermic, you don't make as much insulin, which therefore puts you at risk for hyperglycemia, as well as you can see the other things as well. I don't need to read this slide to you. The treatment is going to be to restore body flow to the organs, because remember you have this decreased plasma volume as well as decreased cardiac output. We want to, in hypovolemia, so we want to restore blood flow to the organs. We want to maintain oxygenation to all the tissues and stop bleeding if there's tissue going on. This phase is going to end when your patient is hemodynamically stable. The flow phase usually kicks in 36 to 48 hours after the injury. This is the metabolic response to the stress. So what you can see here is you see a spike in counter-regulatory hormones like your catecholamines, your cortisol, your glycogen. That's all right here. This is going to promote the breakdown of stored nutrients, so catabolism, to make energy more available. As the body stores and tissues are catabolized or broken down, your energy expenditure and your metabolic rate are actually increase. So you're going to be in this hypercatabolic state. So not only do you need more energy, but you're already using your body stores to get those. You can see other things like what happens here with your oxygen consumption, your cardiac output. All these things increase, so you're going to need even more nutrients in order to keep these systems going. The length of the flow can be days, it can be weeks, your patient can even be in this flow phase for months. It really depends on the severity and development of complications. Again, the key here is these patients are in a hypermetabolic state. So let's review what the hypermetabolic response is. This is again from your book. It's figure 15.3. If you can't see it very well, I encourage you to get to your book, because I think this is very clear. So the top part here is showing the different causes. So if you understand that patients who are septic or who have had a fracture are in a hypermetabolic state, or who have had major surgery or burns and are hypermetabolic state, it doesn't matter what's going on. The nutrition management is going to be the same for those. So anybody who's in a hypermetabolic response, you're going to see this really shows you again that pathophysiology of what's going on. And then here's medical management, which we're not going to focus on because we are focused on nutritional management, but these are going to be the 4 keys that we're going to talk about further. So you can see there, we're going to focus on minimizing catabolism or breakdown of tissue. We want to make sure we're meeting protein, energy, and micronutrient needs, because again, if you're not getting enough protein, we're going to start using protein for calories. So remember when we talked about carbohydrates, one of the functions of carbohydrates is to spare protein. Well, that's exactly what we want to do. We want to make sure you're getting enough calories in so you're using protein to make your antibodies or albumin in your blood instead of having to be used for calories. Then you can see down here, we need to figure out what kind of nutrition. Are we going to be doing oral? Are we going to be using enteral and or parenteral nutrition? And then lastly, fluid balance is a big thing, and electrolytes. So we need to make sure we establish fluids and make sure that the electrolytes are balanced by checking, monitoring frequently their electrolytes. All right, so let's talk about some specifics. So this slide right here is going to talk about protein catabolism, which is a big thing that's happening. You can see this is kind of explains why it's so important to minimize the catabolism. We don't want these things to happen. We don't want you to be having to break down your muscle and into amino acids that then your body can use to make glucose through gluconeogenesis. We want to use protein for what protein is used for. Because otherwise, things like increased death, impaired wound healing, increased risk for infection, and impaired immune system functioning are going to occur. So first of all, we need to know, when do we assess someone's nutritional needs? Well, we want to do it as soon as possible. Now, clearly, if this patient is not hemodynamically stable, like for example, they're bleeding out, I'm not going to be assessing their nutritional status. My priority is to stop the bleeding. Once bleeding is stopped, then I'm going to assess nutritional status. I want to remember that things like age and prior nutritional status definitely influence these requirements. The primary goal here of these patients is we want to protect their lean body mass, and we want to prevent or we want to correct any malnutrition that they're currently having. So how are we going to do that? So let's talk about what nutrients need to be increased. Increase protein. We may more than double it in severe stress situations. We want to encourage additional protein intake to make body proteins for defense, like immune function and recovery, like bone growth after a fracture or surgery, and spare the patient's lean body mass from being broken down for gluconeogenesis. We want to increase calories. This is very individualized. There is multiple predictive formulas that can take into account things like a patient's basal metabolic rate, their temperature, their BMI, the cause of the hypermetabolic state, and their body surface area. There is not going to be any specific one that I am going to require you to memorize or be able to use, but I want you to know we need to increase protein in these patients, we need to increase calories in this patient, because this is what's going on. This is the rationale why we're increasing the calories. Well, just like I mentioned before, we want to make sure their fluid balances as well. So we need to increase water. This requirement is it's usually how much a patient needs is based on their age. Sometimes we take their weight and urine output into consideration. Especially, we want to replace anything that's lost. If your patient is throwing up, has a fever, has diarrhea, or any sort of drainage, those are all ways that the patient is losing fluid, and we need to correct that. We need to replace those lost fluids. At the same time, remember, we like homeostasis, so just because some is good does not mean more is better. So we want to make sure you're not overhydrating. Because one thing is decreased renal output is a frequent complication to metabolic stress. Therefore, we don't want to overwork the kidneys as well. And then vitamin C, we need to increase vitamin C for these reasons right here. You can see, look at how high we might actually end up going because a vitamin C deficiency results in an increased incidence of wound dehiscence, which means wounds breaking open, defective collagen formation, so these wounds aren't healing correct, and decreased wound tensile strength, which means that wound is easier for it to dehiss open. So we want to make sure we're definitely getting enough vitamin C into these patients. We're usually going to actually even supplement. Like, it's going to be hard. That's why I put the word supplement here. It's going to be hard to consume this much vitamin C. This slide just goes into the other minerals and vitamins that are important. What I want you to know is that we're going to use supplementation usually for vitamin C, zinc, and vitamin A. And that usually we can get the rest of these, like the iron and the vitamin K and the folic acid and B12, if your patient is meeting their caloric needs are being met. All right, now let's talk about specific disease states. So if your patient is septic or has had a severe traumatic injury, what do you need to know about that? Well, first of all, what is a traumatic injury? So I'm talking about things like stab, gunshot wounds, motor vehicle accidents. Either when your patient is septic or in a traumatic injury, hyperglycemia is going to be common. It's caused both by an increase in the gluconeogenesis by the liver and a decreased intake by your cells. And remember too, when we looked at the ebb and flow phase, your insulin levels are going to be depressed, and so you're going. It's all again more reasons why they're going to see a hyperglycemia is common. Do you need to understand the reason behind it for the assessment or testing purposes? No, but you do want to know that hyperglycemia is going to be common. So we're going to be doing things like checking blood sugars. The other thing too is that stress can cause induced changes like skeletal muscle not taking as much glucose. So another reason why. All right, then I want to look at things like what specific micronutrients do I need to make sure the patient is getting enough of? They need to make sure they're getting enough of vitamin A, vitamin C, calcium, and zinc. Those are the 4 keys micronutrients. Again, this patient is going to be in a hypermetabolic state, so they're going to need to get plenty of calories, plenty of protein. All right, what do you think when your patient has a fever? What do you think you're going to need to increase with that? So remember they are in this hypermetabolic state. So if you need to support this higher metabolic rate, we're going to need to have more calories. And if they're having a fever, we're going to need to replace fluid loss through sweating. Pressure ulcers. So nutrition therapy plays a key and a crucial role in treatment of pressure ulcers. Do you need to know the specific numbers of calories and protein? No. But I put those in there so you can see the differences. So they do need to increase their protein. We need them to getting a little bit more calories. Do you need to know these specific vitamins and minerals for pressure ulcers? No. But again, we want to make sure all it says on here is to meet the RDAs for these. So we just want to make sure they're getting good nutrition. Want to make sure they're getting enough hydration, which I thought was actually quite interesting because maintaining adequate hydration is necessary to maximize healing of pressure ulcers because dehydration decreases blood volume, which thus reduces the delivery of the nutrients, the oxygen, and the immune cells to damaged tissue. All right, our good friend, protein, energy, malnutrition. So first of all, you need to figure out, is it primary or secondary? Secondary is really going to be caused to an inadequate intake caused by some disease state. If you look in your book at Grodner book at figure 15.6, you can actually see examples of kwashiorkor. So what we can see here is when we look at labs, the albumin and prealbumin will be in the low category. Kwashiorkor, again, remember, is an acute illness, so this happens very quickly. And then you can read right here, this is what they're going to look like. Reason why we're concerned about it, big thing here is delayed wound healing. Especially when you look at those pictures, you can actually see they actually sewed, because the tensile strength of that wound was so bad it dehisced open, they actually re-sewed it to try to help bring it back together. Now marasmus, what's interesting about them is their lab tests will actually usually look normal. This is a chronic thing, so we see this over a longer period of time. They're going to look thin, weak, listless. They're going to not have any skeletal muscles because they've been catabolizing them for energy. However, their immunocompetence and their wound healing is usually preserved. A big thing we need to be worried about with them is if you too aggressively replenish their nutrients, this can actually cause refeeding syndrome. And we're going to talk about that more on the next slide. Then there's actually this thing called marasmus kwashiorkor mix. So for example, you have a malnourished older adult who falls and breaks their hip, so they have a hip fracture, so they have surgery after that trauma. That can actually be an example of acute stress that occurs in a chronically malnourished person. This can be life-threatening. You really need to identify what is the predominant protein, energy, malnutrition to treat. So if they have more kwashiorkor, we want to treat the kwashiorkor. If they have more marasmus, we want to treat the marasmus. All right, what is refeeding syndrome? You definitely need to know refeeding syndrome. So what happens is the patient's body is actually adapted to that starvation state with that marasmus, because remember, they need more calories and more protein. We see this in up to as much as 34% of our critically ill patients actually can have refeeding syndrome, so they're high risk. Other things